better. Hi, good afternoon. My name is Adi Zamir, and I'm the founder and CEO of Pink of You. Before I start with the presentation, I want to tell you a few things about myself. Well, as Mirav mentioned before about selling lemonade, I didn't sell lemonade when I was 5, but I was an athlete and I ran over hurdles. Sometimes when you watch the atlas, it seems so easy, you know, especially if you run only 400 meters. But you have to be very accurate and very precise. And I think that maybe if there was a sign about being an entrepreneur, maybe that was a sign. Anyway, I started my career as a teacher, as a science teacher after the military service. You know, in Israel we have military service mandatory. And I was a teacher for around 2 years, but I felt that something is missing about my work, on my passion every day. So I find a way to collaborate to technology and companies, enterprise companies, with technology and what I knew, which is how to learn, how to teach. And this was like coming from the back door to the world of intelligence and homeland security systems, which I worked for a few years. And I worked 11 years in one of the biggest companies, Nest Technologies. It's a big integrator. And after 11 years as a VP, I felt that this is the time to the next thing. And I joined a startup that developed technology for early detection of skin cancer, especially melanoma. And about 2 years ago, I was in India as part of my work, and I asked my host to take me to see how they implement an oncology technology in development countries. And one of the meetings was with the general manager of a huge medical center, and he said, we're not able to take care of people that have cancer in the first and second stage. It means early stage. If they have the resources, it means that they can pay, we can try to save them lives in the third and fourth stage. Well, I was shocked because he didn't say anything about prevention, anything about early detection. And I thought to myself, if we will be able, as we did in intelligence systems, to map and to predict who is going to be the next case, then we will have a better world. So I look for the combination of entrepreneurship, globalization, medical or health field, and social impact, and this is how Pink started. So every 19 seconds, there is a woman in the world that diagnosed with breast cancer. That's enormous numbers. 1 of 8 women will be diagnosed with breast cancer during her life, and in general, 25% of all kinds of cancer are breast cancer. Breast cancer is the second cause for women deaths worldwide. So we can understand that it's a huge problem. So a few words about the problem. 50% of the diagnosed population has already knew. How? Because they have family and genetic background. There is someone in the family, the sister, the mother, the grandmother, someone. It's like an alert, okay, for that woman that might be diagnosed with breast cancer, so she can take responsibility, and also the insurer, they know what to do. But for the other 85%, it's a surprise. One day, a woman feels something odd in the breast, she goes to the doctor, and guess what? She's part of the statistics. And she had no idea. And we are focusing on this population. This is a partial list of risk factors. Maybe you know part of them, okay? If we are not sleeping enough at night, it's a risk factor not only for breast cancer, because at night we do all the repair processes. And the gene, like the BRCA gene, is doing the same. It doesn't allow us to repair the breast. Others are BMI, it means high weight, okay? And especially if we gain a lot of weight from the age of 18 to our menopause, this is one of the parameters that allow us to predict, and later we talk about it, how to teach the machine to help us to calculate the risk score. Hormones this is one of the controversial issues. Is it good or not to take pills, hormones, and, as part of IVF or any other situation? And the answer is depends. It depends on many other parameters. Alcohol, exercise, it's always good to do. Sports, you know. Breastfeeding is good for us, okay? It's decreasing the risk, for example. And breast density, which today is the leading risk factor, unlike age. And most policies are based on age. So every woman here, like in Brayola that we saw before, that know her cup, ABCD, breast density is ABCD also. So you should know your breast density. If it's high, it means higher risk. So let's see how it works, what we do in pink. This is Linda and this is Kyra, and you see that there are 3 risk factors, for example, like hormones or others that I show you in the list, and they have different risk score. Linda has 85 and Kyra have 70. So it's obvious, okay? Linda have higher risk. But, when we see Deborah and Naomi, we see that they have the same risk factors. And we see that they have the same risk score. But the measurements are different. We can't say that it's obvious. So what we do is learning the leading risk factor of each woman. That's from a list of many, many risk factors that are from the environment, behavioral, biological, and others. So how can we help them? We can tell Deborah, for example, that if risk factor is very high, maybe she should decrease her hormone use and discuss with her doctor. We're not telling her not to take. We just tell her, please consider alternatives. And for Naomi, maybe we should recommend that she will decrease her alcohol intake. It doesn't mean that she won't take alcohol. It means that just she had to decrease it. Another important thing is that the measurements of the risk factor are accelerating during around 20 years of our lives. This is why we see more cases over the age of 40 or 45. It means that if we will be able to manage, to calculate and manage the risk factor management, we will be able to decrease the risk factors. So what we have today is self-examination. In many countries, the governments and the HMOs trying to encourage women to do self-examinations. But usually, it's not very effective. Even though we should know our body very well, usually we miss it. And when we feel something, usually it's later stage. Clinical exam depends. According to the statistics, 70% of the women around the world are not going to their annual check. And you can understand very easily that if I'm not going to my annual check and I'm not going to see the doctor in the clinical exam, he won't be able to help me and to check me better than I can usually. And screening, we have mammography and we have ultrasound. Mammography is used and more effective for women that have low density, and ultrasound for high density. But we recommend usually to do both, okay? So we're not trying to replace all this. We're just trying to give a personalized risk assessment for each woman that will know, together with the insurer, how to treat herself. This is the $34 billion is the direct cost of patients that are diagnosed with cancer. $34 billion. It means that if I don't know that I'm part of the statistics, if I don't know that I'm in high risk or extreme risk, like genetic and family history background, it means that I will know in late stage. And that means more cost and more direct cost. There are also indirect costs like psychologists and other physicians that I need over the way, not only chemo and others. So what we offer is to improve the early detection, because if I know that I'm part of the diagnosed population, I will know how to treat it in early stage. To reduce the treatments, because if I will be part of the statistics, it will be in early stage. It means a small surgery, for example, okay? And then I can go back to my life very easily. And recall costs. Sometimes because of many mammographies and many checks, we can see the differences. So they call you back, do another one, okay? It's high screening also. So this is another thing that we try to reduce. And of course, the mortality rate. Now, PinkoView is implementing breast cancer as a beginning, but we also see ourselves covering other cancers like ovary cancers and others. And that's something that will be in the future. So how it works? We ask the woman questions, a list of questions that allow us to take the measurements of the risk factors. It's like a personalized risk profile. And then we process it and we compare. We compare the data of that woman to other women, okay? Part of the women that we have in the data were already diagnosed, so we do a retrospective data. We learn what was until the day that they were diagnosed. There are a few scales that we are comparing. We're taking the data, we compare it once to one scale, and then to another scale, and then for the third scale. This is part of the pattern that we have. And after 1 year, then we start to compare again. So it's not a one-time check, it's monitoring over time, because it's like an equalizer. I take the measurements, I see what is the aggregated score, I try to evaluate it, and then I can predict. And I can help and assist the woman how to reduce it over time. At the end, she gets the risk assessment, but not only she as a patient, but also the doctor. Because think about him. He sees a patient every 7 or 10 minutes, depends on which country, and the health policy. He doesn't know anything about me. He asks me, do you have a family background? Were you diagnosed with breast cancer? I said no. So am I a part of the 85%? It's like a black hole for him. He doesn't know what to do. He doesn't have the tools. And if I would give him a calculator, he can't do anything with it, because it's something that you have to research and to calculate from the past. Another thing that we do is to take the pink indicator, this is the result of all the things that we do, and combine it with another field, image processing. You know that part of the process is going and do the mammography. Now, today there are a few alternatives. One is a physician review the image and give his report, whether there is something suspicious or not, or do I need a surgery. But today we see more and more companies like ICA, GE, and others that after I do the mammography, they scan it and do auto image processing. It means that the physician doesn't see, the radiologist, he doesn't see the image. He gets only the images that have high risk based on the machine learning, based on a machine. So there might be mistake. Today the average accuracy is around 90%. But if you miss only 1%, for a woman is 100%. So this is the place when we try to combine the pink indicator, which is based on clinical data, and if it gives a high score, but the machine do the image processing and give low score, it means normal, the physician will review the image. And this is how we try first to teach the machine of the image processing, and on the other hand, we try to help the radiologist to have better decisions by using it. For example, if he sees high breast density, it can be for many reasons. Maybe this is a genetic issue. Maybe I was born in Asia. Okay, Asia have high breast density. Maybe I have a depression and I'm taking pills for depression. That's changed the breast density. And maybe I try cannabis from time to time. That's also facts. So it's very important to know what is the reason. And they don't have Usually they don't see the patient, or they don't have the time to ask so many questions. So while I'm registering for the next meeting for the radiologist, or I'm waiting outside before the mammography, I can fill the questions. It takes a few minutes, and it can help for all of us. So as I said, we are kind of decision support system, like plug and play of the pink indicator with other things. We give personalized recommendations. It means that if, as I gave the example before, my leading risk factor is hormones, so this is the recommendation that I will get, and someone else will get another one. We are evaluating the current risk, but also the future risk, okay? Because we able to monitor, and as I said, to compare it to all the data that we aggregate and collect all the time. It's non-invasive, and you can use it very easily. All you need is an internet. Part of the questions that we ask are like replacing blood tests if you don't have the ability to take blood tests, like in developing countries. So we ask about symptoms, and then we can evaluate and calculate. Very accessible, as I said, just an internet and long-term monitoring, because we have at least 20 years to do it. Because we do many transactions of data using the cloud, of course, we have the data. This is one of the assets that we have under the GDPR, of course, and all the others regulation. We use it in an archive, and we also think about using blockchain, because we think that the next thing and the next trend is that I will have my personal data. Because in Israel, for example, you go to the HMO, usually your parents are sending you to the same HMO when you were a baby. And you're staying with the same HMO. But if I would try to replace this HMO, it's like my health history will start from today. Nobody will take my history to the next HMO, which is a huge problem. So part of this, we can find a solution by using the blockchain for medical. And I think this is part of the thing that we intend to do. So we are early stage startup. As I said, it's about a year and a few months. We started with a market research because I didn't know anything about risk assessment for breast cancer. And because it has a huge impact, this is why I chose to start with breast cancer. We had a pre-seed investment, and we took part in one of the best accelerators in Israel, 8200 accelerator. 8200 is one of the elite units in the military, in the intelligence in Israel, and they take 10 startups and try to accelerate them in 5 intensive months. So we were part of that. We won the INCO prize. It's an organization that supports startups that have also social impact, and we won another competition in China. And now we are running the POC in Israel. We collect the data in parallel in South Africa, and we are about to start in France. At the beginning of next year, we will have a multi-language platform, so probably we get to Slovakia also. And then we will have the initial model that will allow us to duplicate it. This is part of our team. We work together from a few countries, from Australia, Israel, South Africa. It's amazing today that you don't need really one place to work, but we see ourselves as a game changer in the field of breast cancer. So this is it, and I'd be happy to answer any question. Thank you.